this lecture, I will show you new technique because we know that on B mode we have sometimes low specificity and we would really make biopsy for malignant lesions. So we want to improve our positive predictive value of malignancy. And I will show you three new techniques. Breast elastography, it's not a really new technique, but I will show you what is new with in Canon, the super microvascular imaging, and I will show you first preliminary experience of a fuse ultrasonography and MRI for breast imaging. So very quickly, because I think most of you know the principle of elastography, you know that there is two types of elastography. The strain elastography, this consisted in manual compression and the evaluation of tissue deformability. There is some classification to evaluate qualitatively the deformability. And the other type of elastography is shear wave elastography, which evaluates the speed of movement of the waves, the elasticity. And the main advantage of this shear wave elastography is to reclassify complex cysts, because sometimes it's difficult on B mode to be sure the lesion is a cyst. And typically on shear waves, there's nothing inside the lesion that suggests the fluid content of the lesion. So we know that we can characterize the fluid, but also and mainly we will characterize the solid. And the solid, we have also classification, and you know, you must be careful because the color map are not always correlate between strain and shear waves. And depending on the type of the morphology on elastography, you will have lesions that can be classified from benign to malignant for characterize this solid lesion. So here, an example of strain elastography. I will show only one example because in our practice, finally, we use not so much this technique because the main limit of this technique is lack of reproducibility. Here you have an example of quantitative analysis, and we know that the malignancy is suggested when the ratio is higher than 4 when you compare the deformability between the lesion and the adjacent normal parenchyma, like in this example. The second type of elastography is the shear wave. You have two types of analysis. The first type is a descriptive analysis, and you will be able to see the propagation of waves in the tissue, like in this example. You can see that in this cancer, there is a deformation of the wave. You have that. And in a benign lesion, you will have no deformation of the wave. So it's very basic, but it's the first approach, which is a qualitative approach, and which can be the first step when you perform shear wave analysis. So here, an example of a lesion that is detected in the external quadrant of the left breast. It's a speculate lesion, corresponding morphology on a suspicious lesion on B mode. And you can see the result of the descriptive analysis on shear wave with a deformation, typical deformation of the wave, with a typical here stiffness which is higher around the lesion, and sometimes you can have nothing inside, but it's typically suspicious with this high presence of stiffness around the lesion. So I think it's interesting to also use quantitative analysis for elastography because sometimes you can have some artifact on the description of waves, and it's more strong for the analysis of shear waves. So in this example, the patients have a mass here. You have the view of the mass in the orthogonal plane. And if we look at the elastography, there is a modification of the stiffness with ratio which are between 4 and 2. And it's important to make several regions of interest because sometimes a lesion is heterogeneous and you need several regions of interest, and this lesion was a papilloma. So if we look at the different shear wave techniques in the literature, in this paper, they compare two different systems. And you can see that the performance is quite similar between the two systems. And you have an evaluation of the Emax, which is and the E-mean. Probably the E-mean is stronger than the Emax because it's more reproducible. And you can see that malignant are around 50 kPa versus benign, which are around 20 kPa. So here, an example, a 73-year-old woman referred for breast screening. On the right breast, there is an irregular mass at the union of the upper quadrant on the right breast. This lesion was an invasive lobular carcinoma, and you can see that the value of the stiffness is very, very high, 164 in this example, with all sign of malignancy, whatever the image you can see on elastography. So when we look at the big publication and the evidence-based medicine for elastography, this meta-analysis, I think, is quite interesting. It's according to the methodology, show that there is some heterogeneity, and we know that between the study, we have not a very good coefficient, a CADAS coefficient, which is quite high, but I think it's interesting to see that elastography mustn't be used only. You must be used in combination with B-mod, because you can see that using only ELASTIScore, you miss some cancer with a sensitivity with only on 80%, but you have a good specificity. And in B-mod, it's exactly the opposite. So the best way, finally, to analyze your lesion is a conjunctive combination of elasticity score and B-mod to have the best positive likelihood ratio of malignancy, which is clearly better when you combine the B-mod with the elasticity score. What are the limits of the breast elastography? The main limit is also, even in shear wave, the problem of the intra-observer reproducibility, which is low to moderate. And there is some artifact here. I take 2 times the image with different compression, even on shear waves. You can see that you can completely modify. If you just look at the coefficient here, it's 94. In the same lesion, it's 47. That's why it's very important to make a ratio, because if you make a ratio, even if you made a strong compression, even if you don't want, the ratio allow you to be more reproducible between the evaluation. But even if you use a ratio, we know that there is some false negative, and these false negative are the lesion which are low-grade lesion with DCIS and also deep lesion. And here, in this example, no problem on B-mod. This lesion is an hypoechoic lesion with halo, so the classification using the B-mod is typically suspicious. But when you apply the elastography, you can see that the coefficient is quite low, and probably it's because it's a very deep lesion, and we know that there is some false negative in this type of lesion. So the second technique I will discuss with you is the super microvascular imaging, which is a new algorithm to detect microvascular movement with a high image frame. You will have a simultaneous detection of arterial and venous vessels. There's no movement artifact. It's the same spatial resolution than 2D imaging. And you will be able to detect distal perfusion, and you don't need any specific settings, so it's very easy to use. So there is a publication in the literature made last year who describe the feature you can use to characterize the lesions. The malignant features are a number of vessels higher than 6, when the vessels are branched, and when the location of the vessel are both central and peripheric. And when we look at this monocentric study, there is an inclusion of 191 lesions, 99 benign and 92 malignant lesions. And they create a score based on these 3 criteria. You have benign lesion when there's 0 vessels, or when the vessels are dotted vessels, and when the distribution is peripheral or central, and malignant when you have more than 6 vessels, branch with shunt and penetrating lesion, and the location of in the periphery and the center of the lesion. And you can see that the performance is good, and it's better when you add B-mode with SMI in comparison with B-mode with typical color Doppler and B-mode alone. So it's a preliminary work because you have a high prevalence of malignancy in comparison with in your clinical practice. So that must be confirmed, but I think it's a good first step for this new technique. So here an example. This lesion was regular nodules, which can look like fibroadenoma. When you look at the elastography was not so difficult. There's no deformability, important deformity of the waves. And when we look at the SMI, you can see that you have a lot of microvessel everywhere with some branch microvessels. And this lesion was not a fibroadenoma, but was an IDC grade 3. Here another example, you have a lesion which can be a complex cyst or a solid lesion. The elastography is reassuring, it's no problem, there's no deformability, there's no flow on SMI. This lesion was a complex cyst. Here another example, it's a lesion we detect on MRI. It's a lesion with a bright signal on T2, so probably a lesion that is quite soft. And when we look at the elastography, here you have the elastography. Finally, an elastography, there was a modification with a lesion which is quite stiff. With a SMI, you can see that there is some peripheral and branch vessel in the lesion, so potentially suspicious. And this lesion was ADC, SBR2 cancer. Another example also, which is an interesting example, because I think it's important to have good settings. In this patient, we stop this lesion on the prospective management of this patient, and this lesion stay well visible and suspicious on breast tomosynthesis and on synthetic mammo. So we perform at the beginning ultrasonography and can see that at ultrasonography it was a little bit suspicious, but not so much. There was nothing on SMI, but you can see that the image is not good because you can see that you have half of the image which is in the chest, so it's really not good. At the follow-up, the patient, there was an increasing of the lesion, and this lesion was finally a breast cancer. So be careful when you apply all this new technique. The basic things is to have an optimized settings for the B-mode and for all this new technique. Here's some example. It's a patient who was referred for nipple discharge. You have here a beautiful cyst with a papillary projection. You know that with this type of lesion, elastography is not so good. And we perform SMI, and it's very beautiful because we can have the flow inside. There's not so much flow in this lesion. So the first hypothesis was a papillar carcinoma, but we perform a biopsy, and finally this lesion was a benign papilloma. Here, another example of nipple discharge on the right breast. If we look at the mammo, there is a mass in the retroareolar part of the right breast. If we look at the tomo, this lesion is well seen on the tomo, and we have this lesion on the B-mode with some flow at the periphery of the lesion. And we perform MRI in this patient, so they confirm the lesion on the right side, but this MRI also allows to detect another lesion on the left side. And this lesion was classified by RADS 4 because the morphology was not so much suspicious, but we have a curve that with early and strong enhancement and a little washout. When we look at the Doppler, there was a flow, but we don't know if this flow was really present or no. But when we apply the SMI, no problems. It's sure the lesion is there, and I think it's useful to target your lesion when you perform your second look ultrasonography to be sure you will keep this papillary lesion. Another example, 62-year-old woman with personal history of bilateral breast cancer treated by conservative surgery, and there is an person since 2 years of retraction of the left nipple, no problem, clinically there's a problem. This retraction is due to this very suspicious mass, which is speculated, and we have the problem of, is there an evasion of the areola? Probably yes. Here, the lesion, when you analyze, elastography is very suspicious. That's true that in this type of lesion, speculate lesion, you can have finally a negative SMI, but the combination between elastography and SMI help you to detect everything, because finally the stiff lesion, which can be speculate like luminal A breast cancer, have usually are malignant on elastography and probably less vascular as you're using SMI, but the lesions that are false negative on elastography, especially the lesions that are triple negative, will have high vascularization. So you can, combining both technique, have decrease your number of false negative. In this patient, when we apply SMI, it helps you to detect little flow between the mass and the nipple, and this patient have a complete invasion of the nipple. For the characterization of axillary lymph node, SMI could also be useful, because in a normal adenopathy, you will have a tree which is completely homogeneous tree. You have that on Doppler, but I think it's better visible on SMI. You are totally able to see the vessels are everywhere in the lymph node. And what is interesting is this patient is an example. You have a right cancer, breast cancer, no problem with that. And we find an adenopathy, and when we look at that, you can see that there is some vessel except in this part of the lymph node. And so we focus our function on this part on the lymph node and find little metastasis. So it could be useful also to target the good part of the lymph node and to take the part which is invaded during your punction or biopsy. So the last part is about fusion. So it's a preliminary experience, and we think this technique could be useful when you perform your second look ultrasonography, because you have to detect subtle lesions, and even if the correlation is not so easy, because when you perform an MRI, the patient is in prone position, and when you perform ultrasonography, the patient is in supine position. Usually when you perform your second look, you use many lesions that are around the lesion you are looking for to be sure the lesion is at the good place. And you will see that when you use fusion, it's helpful because you are more confident in the location of the abnormality you detect. So here the first clinical case. It's a 73-year-old woman who referred for MRI for staging of invasive lobular carcinoma on the right breast, so no problem with this lesion. And when we perform the MRI, you can see that we have an additional lesion, which is different than the index lesion. And you have also another lesion on the opposite breast, so that means you will need to search this lesion using ultrasonography. Here you have the picture of the two lesions on the right breast and the lesion on the left breast. How do you do? It's quite easy, because when you perform MRI, you use 3D sequence, and you will import the T1 weighted native sequence, because it's useful to have also the normal breast parenchyma around. You will positioning your probe, and you will do the synchronization with the position of the nipple. And so here you have the lesion there. So it's just to show you here the lesion. Okay, and so you have the lesion there. So when you move your probe, you move also the MR sequence. So we will begin in that case. We have an index lesion, and we will search the second one. So we are on the index lesion, and we go down, 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 and we will find here the lesion is there, and you can see that you have the lesion there. So it's not completely similar, but you are sure it's there because you begin at the lesion index and you go down. And so when you find the lesion, you are sure that correspond to the lesion in MRI. And so here another video, it's the same. And we perform the biopsy under fusion. We can perform with fusion or not. And the lesion, no problem, is there and correspond to the lesion there. So I think usually when you perform second look, you are not always sure it's a good lesion, but using the fusion, you are more confident. It's our feeling with this new technique. On the left breast, you remember, there was a detection of mass in the opposite breast, and this context of lobular carcinoma. We must be very careful with this type of lesion. And also, here the fusion, you have the lesion there, and you also, in here, you have that correspond, I think there's another video, yeah, here, that correspond to this lesion. We are in the right place because we are on the medial part of the breast, not on the anterior zone. We are on the medial zone, like that. We have the fatty part of the breast here that corresponds to this portion in MRI, and the lesion is at the superficial part of the medial zone of the breast, so it's probably the good lesion. Here, another example. This patient was a 55-year-old patient with left nipple discharge. And when we performed the MRI, we have a mass, which quite regular, which enhance according to time intensity curve type 2. But we have, using the abbreviated protocol, early enhancement. So with the context of nipple discharge, we need to find this lesion and to biopsy this lesion. And typically, it's not so easy to biopsy this type of lesion under MRI because it's quite superficial. And technically, sometimes it's difficult. So it's easier to find using ultrasonography. Here, the B mode, when we perform the fusion, the lesion is there. There was another lesion here, but we are looking at this lesion because this lesion was spontaneously bright on T1 before injection. And when we look at that, we have the nipple there, and on the very superficial part, we'll find the lesion that correspond to this lesion here and here. Okay, it's the last slide. Okay, I'm sorry, it's a little big. Perhaps I can do that. No. Okay, it was the last example I have to show on the fusion, so I think it's over. So what I want to give the message, I think this new technique need to be used with the B mode, in combination with the B mode. And if the B mode is suspicious, you need to perform a biopsy. But I think for lesions that look like benign on B mode, you can combine the elastography and SMI, and I think it's a combination of both techniques that help you to not miss any cancer, because sometimes you can have cancer, especially in young women, BRCA mutation, can look like adenofibroma, but it's very triple negative lesion. These lesions are soft on elastography, so you can miss it. The elastography will not help you, but SMI can help you to recognize this cancer. And in the opposite, sometimes in lesions that are subtle distortion, elastography will be good, and SMI less good because low vascularization. And in that case, the combination of both helps you to optimize your specificity in all lesions. Thank you very much.